myself for that video. All right, are we good? We're going to get started? All right, welcome you guys. Thank you so much for coming tonight. I see a lot of friendly faces in the audience and a lot of new faces in the audience, which is very exciting for us. So this is my home facility, so I'm very excited to host our event here. So before I get started, I always like to ask some questions. Oh, let me get back in focus. I always like to ask some questions just to kind of get to know some of the people in the room. So is it anybody's first event? First event? Welcome, you guys. Thank you. Thank you. Very nice. So last month we did an event. It was, well attended, just like this one, and there was a lot of people that it was their first event. So we always want to shout out, for the first event. Are you guys new members? New members and first event. Very good, thank you. Well, welcome you guys. We're going to tell you a little bit about what we do here, and I think you're going to get an opportunity to hear from a great panel, and I hope you got an opportunity to network with some of your colleagues and then your peers and meet some new people as well. But welcome and thank you guys for joining the organization. Is there anybody in the audience that's not a member? Not a member. Okay. So for you guys that are not a member, raise your hand again. We have some great information out there about the benefits of becoming a member, and I hope after tonight and after my little spiel here that when you leave here, you sign up to become a member. But welcome and thank you guys for coming. We always appreciate opening up our professional organization to people who are interested in being friends with us. So thank you guys. How many fellows do I have in the room? Fellows? Look at this, fantastic, great. So for those of you who don't know, ACHE is the only professional healthcare organization that provides people with board certification for healthcare executives. Just like physicians have board certification, ACHE is the national organization that gives that certification. So you saw the hands in this room. If any of you are interested in learning more about becoming a fellow, raise your hands again, my fellows. Raise your hand again. Very good. For anybody who's interested in learning more about becoming a fellow, approach one of these people in the room. Maureen, raise your hand. Do you guys know that Maureen, who works here, she's lovely, Maureen is our, and I'm not saying oldest, longest tenured fellow in our chapter. In our chapter. There might be people who are more tenured, but she's the longest tenured fellow in our chapter since the last time I checked. So thank you, Maureen.
I'm willing to give up the honor, though.
I didn't say you were the oldest. All right, very good. Okay, how many people in the room are actively pursuing their fellowship? I know there's a lot of you. I've spoken to a lot of you. Great, actively pursuing, good. We love to see it, and maybe next time or the following time, you'll raise your hand. We always, each year, have some statistics about fellows in our chapter and getting new fellows. We have a lofty goal this year. We're getting close, though. We've had a lot of new fellows just in these couple months, so I'm excited to see your name on that list. My board members, if you can please raise your hand. Thank you guys so much for attending tonight, but also for all the work that you guys do. ACHE is a volunteer board, so these individuals who raise their hand as their second full-time job really are active helping our chapter. And we, as a board, are really proud of the work that we do because, we like to, obviously put on these education events, do networking events, and make sure that we have a very, very active chapter. And so this board is the board that makes it happen. So thank you guys so much for being here tonight and for the work that you guys do. All right, very good. Did I have any other questions? I don't think so. I don't think so. Okay, very good. So I'll go on to my presentation. I'm sorry, Charles, but I have to hit the button here. All right. So just, I always like to start our events talking about our sponsors. We cannot do the work that we do, put on the events that we do without our sponsors. And we are so, so fortunate that so many people in South Florida want to sponsor our organization because, believe in the mission, believe in the vision, but also attend our events and give people great networking opportunities and great, opportunities besides that. So shout out to our 2024 sponsors, and for our platinum sponsors, Airmark Healthcare, the Beck Group, Florida Blue. We have a representative from Florida Blue. Where are you, Juan? You're out here somewhere, but thank you, Florida Blue. LYNN Memorial Healthcare System. I know there's a lot of Memorial employees here. Thank you guys for your sponsorship. And NSU Florida, our platinum sponsors. And then our gold sponsors, Baptist Health, Baxter, U Health, Broward Health, Ponte Moran, University of Miami Department, University of Miami Department of Health Management and Policy, Cano Health, VITAS, FAU. There's a lot of FAU people here. I was just gonna say, where is one of my most favorite people, Rudy? Rudy has been a supporter of our chapter at ACHE for a very long time. He has been so gracious and has invited a lot of us, myself included, to speak at his classes. He is a fellow himself, and he has always spoken so highly. So Rudy, thank you so much for your support, and to your students. I didn't have a professor like him when I was going through school. You guys are so lucky. He's a fantastic guy, so thank you, Rudy. Wellington Regional Medical Center and Nicholas Children's Hospital. Our silver sponsors, Barry University, Cleveland Clinic, FIU, Jackson Health System, Miami-Dade College, and South Florida Hospital and Healthcare Association. And then our media partners and supporters, the Broward County Medical Association, South Florida Hospital News and Healthcare Report. It's where I get all my news from, and the Dade County Medical Association. So again, we really can't do this without our sponsors, and we always like to shout them out. All right, I won't go into our vision, mission, and values. Most of you guys here, if you're part of our organization, you know the good work that we do, and we really do live by these vision, mission, and values. Here's all of our 2024 board members. Several of them weren't able to be here tonight, but again, this is a very active board. And one of the things that I'm very proud of is we really try to have a board that comes from a variety of different organizations, a variety of different titles and so forth. So anybody on our board is always willing to take a phone call or an email from anyone who wants to know more about the organization or just wants to talk about something. And we have a variety of organizations represented here. All right, so ACHE is a national organization. I'm sure you guys know that, and these are some statistics, and it's really astounding to think 48,000 plus members, the amount of 300,000 plus education hours provided across the country, and 142,000 podcast plays. I didn't even know that ACHE had podcasts till recently, and I had listened to one, and it's fantastic. So if you're looking for something to listen to in a podcast, but really you can tell that ACHE as a national organization is really committed to their membership, by these statistics. And then what I'm more proud of is our statistics. So something that we learned this year that I thought was very, very impressive. I think my friend Renee there, who sits on our board, sent me this information. We are the 9th largest chapter in the nation. And last year, Jenna, who's our immediate past president, I know she's here. Oh, there she is. Her and I had an opportunity to travel to Chicago for a conference that ACHE puts on for their board members. And we got to meet with other chapter leaders across the United States. And when Jen and I left the conference, not tooting our own horns or anything, but we were like, wow, we have a pretty good chapter, because people were approaching us. And I'm sure other past presidents who have been to these chapter leaders conference have the same experience. I see Renee shaking her head. People approach us from all over the country, chapter leaders of other chapters, talking about what a great job we do, and we really do a fantastic job. So 1,200 members and growing, right? I have to probably change these slides. 140 fellows in our chapter, that's really awesome. 266 student members and growing, because we get student members all the time. Okay, this is very important. Where's Adrian? Where's my social media, Adrian? Okay. Adrian is our LinkedIn, I call him our social media king, but really LinkedIn king. Does everybody in this room follow us on LinkedIn? Okay, listen, we have 4,000 LinkedIn followers, but Adrian has a goal, 5,000 this year. So, I said this last time, and I probably said this at the dinner, if you do not follow us, you must follow us. You must, okay?
Say cheese.
Yeah, say cheese, okay? You'll find yourself on our LinkedIn page. We are very active on LinkedIn. We post a lot. We put our events on there. We do polls on there. We want followers, okay? We're going to shamelessly beg for some followers. So please tag, post, repost, and tell your friends to follow us, because we need 5,000. Adrian, did I do a good job?
Awesome.
All right, okay, my boss there. All right, so our local chapter, I think we talked about this, but really one of the reasons I joined ACHE, and I'm sure a lot of people joined for the same reason, when I first joined, I wanted to meet people outside of my organization. I wanted to network with people. I was young, I wanted opportunities, I wanted to meet people. I've been a member for a long time, and I've met a lot of friends, a lot of you in this room, through this organization. So really for me, it was networking. As I continued to grow in my career, the education became very important to me. So if those are things that are important to you, your board has the commitment that we will provide education and networking events. We try to do something every month. We have a fun networking event that we're going to announce soon. So really look on our LinkedIn and our website for those events. All right, let me see here. Again, if you're not a member, this information will be available for you at the front desk, so stop and get some of the information, but you get a lot of benefits from being a member. And if you want to talk to any of our board members, if you're not a member and thinking about joining, please stop and talk to any one of us, and we'll tell you a little bit about the benefits of being a member. I talked a little bit about the fellow the fellow certification. There's requirements for the fellow certification. Recently they changed. It seems a little confusing, but if you're interested and you want to know more and you want to either start studying for the exam or just start working towards your fellowship, again, we are more than happy to help you with that. It is a big commitment that we make, that we want our peers and members in our chapter to become fellows. So we are happy to help with that. Brian here has helped people with flashcards and study books, and I know some organizations like Memorial does study groups, and so I'm sure they're willing to let other people join in on their study groups. So please reach out to us. We have a lot of contacts of people who are also taking their test. Okay, LinkedIn. I should have put this after that slide, but if you're not following us, you can now scan this QR code. All right, so again, I want to thank you guys so much for coming tonight. We have a great panel, a great moderator. And if I didn't get a chance to meet you, please stop and say hello to me on the way out, because I'd love to meet every single one of you. And then I'm going to shout out our very special food and nutrition team for providing the delicious food and snacks that they provided outside. We host our events at different facilities. We happen to be here today, but all across South Florida, hospitals open up and welcome us and provide food and refreshments and a place for us to host our events. So we are very, very thankful for that. So I appreciate our food and nutrition team for providing this today. Thank you. And then our next event, I'm going to leave this up because this will be the QR code that you scan for our survey. Our next event is April 18th. That event, we will have some information on our website and our LinkedIn page shortly. But our next event is April 18th. It will be held at Memorial Regional Hospital. So thank you, my Memorial friends, for hosting us. And we will have some information on our website shortly. Probably, no, am I wrong? I'm lying? It's not? No, it's not. No, it's not. The student case competition is at Memorial Regional Hospital. Our next event is going to be at Wellington. Yeah, Wellington Regional Hospital. So our case competition for our students will be at Memorial. And then the next education event will be at Wellington Regional Hospital. But thank you anyways, my Memorial friends, for hosting our case competition. All right, so now I have the pleasure, all of our host facilities, which is us tonight, get an opportunity to speak a little bit about something going on at their organization. So I have the pleasure this evening of introducing Ryan. Ryan, why don't you come up here? Ryan is one of our supervisors here at Boca Raton Regional Hospital. He is a member. He's been really active in volunteering and so forth. He's gotten really involved. And he is going to do a presentation tonight. Just a couple minutes about what's going on. You guys see all the construction going on. I'm here, and a lot of people ask, and I said, I'm not going to tell you because I don't want to ruin Ryan's surprise here. So do you have your slides up here? Oh, yeah. Yeah. You're going to have to talk about it?
Talk about it. Yeah. All right, no pictures. Okay. Well, this is my first time speaking at ACE and I get no slides, so we're just going to roll with it. But that's okay. This is actually a really special moment for me. This is a special place because I started here 10 years ago as an X-ray tech working on night shift. And this was a very different place back then, especially from my perspective. This building that we're all sitting in didn't exist. The Neuroscience Center didn't exist. And now we've got all this construction going on, and I've been invited by Brian and Berula to come up here and speak with you. So it's pretty amazing to see what's going on. There's a really great group of leaders here with a focus on not only building this hospital and this institution, but also building up their people and their community. So it's a very special place, and I feel really honored to be up here talking to you all about it. Luckily you all saw all the buildings on your way in, so you probably don't really need a lot of pictures. So I'll just talk a little bit about what's going on. We have a big master facility plan happening right now. There is, of course, our new patient tower. So currently they're working on the 8th floor on both sides of the patient towers. It's really 2 towers technically. And that's going to give us the ability to renovate our existing space and wind up with 455 beds that are going to be all private rooms, which we're very, very excited about. And I think that it's going to be pretty unrecognizable from the Boca Regional of the past few years when it's all finished. Right now, they're actually starting work on the interior, so they've got that going on already. There's 20 new surgical suites going in there, and we're very excited for that. That's going to help decompress what we've got going on in our current OR and help expand our neuroscience services. On the west side of campus, way over there, that you may have seen if you came from the south, we have the central energy plant. which is going to provide several weeks of emergency power for the entire campus if needed. Hopefully we never use it, but they're tying in the utilities for that right now. That should be up and running by next month, so we'll be happy to get that going. And then right across the street from here, you can see out the windows the new medical arts pavilion we have that opened up in January, the first 2 floors. We have a bunch of physician practices that moved in to a beautiful new facility. And on the 3rd floor, we have 5 new OR suites, and they are working on a whole bunch of big ramp up for a whole bunch of new ortho surgeons to get in there and do some new surgeries. So that's been very exciting for us. Also, we've got another project going on at the LCI building. We're installing a proton therapy vault over there. So we're excited, kind of in partnership with Miami Cancer Institute down south. And that is going to bring some cutting edge tech that we'll be able to offer to our oncology patients. So we're happy about that. We had to dig up another parking lot here for that, which makes everybody very unhappy. And I know it's one of Brian's favorite subjects. But it'll be worth it in the end. That's going to open in 2026, so we're really excited about that as well. And last but not least, we have our freestanding ER. That's way out west in the Mission Bay Plaza out in West Boca. It's going to offer 18 rooms, imaging lab facilities, all right there. And it's going to help us capture some of those people that live way out in West Boca and don't have the same access to the resources that we have here on our main campus. So 2026 is going to be a big year for us and beyond, as a lot of the stuff starts to open up and construction starts to finish. I guess that's it for book updates. So now I'm going to go ahead and introduce Brian Altschuler, our VP of Ancillary Services, who's also tonight's moderator, and we'll go ahead and get started with the event. So thank you guys, appreciate it.
Didn't you go to FAU?
Yeah, Rudy's getting his plug in there for
That's
FAU.
right, I got to give my speech in front of my former professors.
Yeah.
So nothing, you got to understand how this went. Ryan has been one of these, high potential leaders that comes to his vice president and says, I want to get involved with ACHE and I want to do more. So normally Harula would have passed it to me and I would have done the introduction. So he's in my office and he's telling me he wants to get more involved. And I'm like, hey Ryan, why don't you do the introduction tonight? Why don't you step up there and do it? It's a great opportunity to speak and really kind of, do more and get involved. Not only does he say yes, but what do we do to him? We switch to PowerPoint because the computer wouldn't work.
My fault.
No, I'm moderator tonight. I'll take it, friend.
Sorry, friend.
Friend.
We had to switch the presentation a bit.
When you work with Harula, by the way, and she says to you, friends, it has a different connotation. It could mean a lot of things. It could mean friend, or it could mean friend. It could be friends. It's got a bunch of different things. But Ryan, you did a great job, and thank you for the introduction. You got my last name right, so that's awesome. Good job with that. So I'm very proud of you. With no slides. We do have an amazing campus going on here, and he really helped us understand that tonight. So my job as your moderator tonight is not as president-elect of ACHE, but to keep the event going tonight with a fantastic group of 3 panelists that we were able to find here in South Florida. And I'm really excited because they all come with different perspectives. So you're going to hear a lot of different angles on inclusive leadership tonight. Why are we talking about inclusive leadership? Why is it important? Before I introduce the panel, I'm just going to get the group involved. Okay. They got to be behind the podium for the camera. Charles, do you know me? I am not, nobody puts me behind the podium. All right, I'll stay here tonight. Somebody help me understand, why is it important? I'm gonna get you guys engaged tonight. Why is it important that we're here talking about inclusive leadership? I'm gonna share our survey results from online. 25 of you who registered tonight were nice enough to complete it for us. But before I share that, I want to try to ask if somebody's brave enough to ask, why is it important for us to be talking about this? Who's willing to raise their hand? And Chris.
Different voices give different perspectives.
Okay, different voices give different perspectives. Good thought. Yes, ma'am.
Because in healthcare, we don't work in silos. We work as teams together to provide that quality care, compassionate care, empathetic care. And we have to include everyone together.
That's extremely powerful, correct, right? We serve a lot of different communities, and the cultures that we serve all have different healthcare needs. And when those cultures in different communities want to receive healthcare, they want to see people, not only clinically, but in leadership, that understand their backgrounds, understand their needs, and are able to meet those needs more importantly. So absolutely. Sir, you had your hand raised too.
Pretty much said what I was going to say. Representation for different patient populations.
No, absolutely. And this is really at the core of why we're here. If you're in healthcare today and you're in an administrative position, you also know, and I'm looking right at somebody I absolutely adore, but Pua Cooper is one of my peers who does a lot around quality. And Pua, what's even happening with a lot of, if you don't mind sharing, with a lot of our regulatory agencies?
Oh my goodness, the inclusivity is being regulated, included in a lot of our metrics. We're being expected to start to look at data in new ways, considering our different races, ethnicities. Are they getting the level of care and health equity that they deserve? So we're just looking at data, the same data we always have, but with new important key components to make sure that everybody's represented and getting the level of care and quality of care that they deserve.
So to summarize, the level and quality of care everyone deserves, and went ahead and really helped us understand that structure. So the question that was asked on LinkedIn, and then we're going to go over and do introductions here with our panel, and thank you all for participating in that. How do you believe inclusive leadership can be further promoted in healthcare? So 25 people responded, and 44% said through mentoring and encouraging different diverse people to get into leadership. 20% referenced more inclusive training, having training that involved different groups of people. 4% spoke more about affinity groups. And does everybody know what an affinity group is? A lot of healthcare organizations kind of approach those on two angles. And maybe, I'll jot a note down here, maybe we'll have our panel kind of talk a little bit about what affinity groups look like and how maybe those can even be linkage into more inclusive leadership. And then 32% talked about diverse decision-making and having leaders that could actually make diverse decisions and represent different populations. So, Adrienne, this is why we get on LinkedIn. So this is terrific that this was out there to help start the conversation. So with that, I'm going to go ahead and introduce our panel tonight. We have three great individuals with us from different backgrounds. And I'm going to actually start here on the end. And we have Ms. Nicole White, who's Vice President of HCA HR East Florida Division and is also based out of Kendall. And she'll tell you a little bit more about herself. In the middle, we have Joseph Zoe Lubchuk, who is Director of the Yes Institute. And he's been in that director role for 5 years. And I was pretty amazed to hear this, but 27 years with the Yes Institute, and he'll tell us all about that. And I've actually had the privilege of knowing Zoe Hernandez-Wolf for quite some time now, who's Vice President here at Baptist Health of South Florida. She's Vice President of our Talent Management and Development Group for 13 years, and prior to that was in retail and hospitality and had a very successful career there too. So with that, I'm going to again turn it over, and Kay, we'll start with you. We're going to have you just turn that mic on. I may have to turn this off. We'll see what we get with feedback. We might have to monitor that, and have you do a little bit deeper of an introduction.
So I really have a big voice. I don't know if I need it. No, whatever you prefer. I don't really need this. So my name is Kay White. I'm Vice President of Human Resources and Equity Coordination. I am in HCA's East Florida Division. I'm responsible for HCA Florida Kendall Hospital, as well as multiple freestanding emergency departments, as well as our dependent health professionals, as well as our GME residency program. So we are heavy in creating physicians for the future. So I have been in equity, inclusion, and diversity for, I will not date myself, but I will say a very long time. A very long time, actually, before I came to South Florida. I was in South Carolina, where I ran a healthcare system there. I began there as their director of HR and equity. and was promoted to Vice President of HR, Equity, and Inclusion, and then became the Chief Human Resources Officer for that system. I was snatched up by a CEO of HCA who said, we're just only going to go to dinner and talk. Well, I have been in this role now progressively for 10 years, so he was a snake, right? He put me into some things and now I can't get out. In my current role, I act as the Equity 9 title coordinator as well for GME. They follow a different set of standards. And I would love to take your questions on all of this. I have a very strong comfort in it.
Great. Thank you so much. I appreciate it, Kay. Joseph, we'll move on to you.
Hi, everyone. My name is Joseph, and I'm just really honored and excited to be here. So a little background about what we do at the Yes Institute. We're a nonprofit organization, and our main focus is on suicide prevention for all young people, but in particular, higher risk groups of young people, which include youth and their families that are dealing with gender, sexual orientation concerns. And also what we're finding out is youth with disabilities and youth that might be neurodiverse also are at high risk for self-harm. We work with a variety of people throughout the community, so medical, mental health, the school systems. I just came up here from Broward County Public Schools, helping administrators navigate some updated changes here in Florida. So that's a little bit about what we do. So how do I see our role being a contribution to healthcare organizations? So many healthcare organizations approach us primarily because they're working on their Human Rights Campaign Healthcare Equity Index rankings. So we go in and we, through consultation, we help them say, okay, if this is your goal, now let's get there. But we like to do this work authentically because while we might have metrics and numbers that look good on paper, if we don't have the authenticity and some of the difficult and awkward conversations needed for true inclusion, it's going to fall apart later on. So we support many healthcare leaders with all kinds of variety of things that come up for gay and transgender patients, people with neurodiverse abilities, and so on and so forth. So that's a little bit about what we do. And we also work a lot in the nonprofit and organizational sectors with government agencies and other nonprofits to help them with their inclusion initiatives also.
Excellent, thank you. And Zoe.
Hi everyone, I'm Zoe Hernandez-Wolf and I'm the VP of Talent Management and Development here at Baptist Health in South Florida, as Brian mentioned. I have been here 13 years. I've never really thought that I would be in healthcare 13 years. I came from the retail and cruise industry and I thought, well, I'll give it a shot. I'll do 3 years and then move on. And somehow I fell in love with Baptist and healthcare, and so here I am. I want to say thank you to Brian and to the board for extending this invitation. It truly is an honor to be here. I'm responsible for the areas of culture, diversity, equity, and inclusion, things like talent management, succession, leadership development, employee engagement, communications, as well as the babies. We have a number of daycare centers, so I'm responsible for our daycare centers as well. I was born in Cuba, right? So my family left when I was 2 years old. We moved to Spain. I was there I was 5. I came here when I was 6. So English is my second language. And I always joke with my husband. I'm like, I don't get that. I'm a Cuban. So I'm like, you'll have to explain that to me. But I also had the privilege to live in Central America, in Guatemala and Honduras in my early 20s. And that was really quite an eye-opening experience, right? Because when you're raised here, you don't realize the privileges that we have. And to live in tiny little towns, I literally lived in tiny little town with dirt roads and, there is no Publix. And it really is very humbling. There literally is no Publix. It really is a humbling experience to appreciate what we have. And so I always bring that with me. And then when I went to Royal Caribbean, this was before DEI was cool, right? I mean, many, many years ago, we had people from all sorts of different nationalities. And so working on board a cruise ship with all those nationalities really opens your eyes to all the different ways of thinking and customs that people bring to their work. And it's like, how do we all work together, and how do we all get along, and how do we understand each other in a way that we're not offended and we're not offensive to others. And I think, you know, as we talk about today, I think that's really important, is that we keep an open mind. We all probably have different experiences and different perspectives, but it's the beauty of our different perspectives and bringing us together that makes us a great society. So I'm excited to be here, and hopefully I have some interesting tidbits to share with you, and hopefully you'll find some value in it. Maybe just one or two.
Well, I am sure they can see what I see. I'm completely humbled that we have a completely inclusive panel up here that I know will share a lot tonight with us. So Zoe, we're going to actually start with you. And I'm going to say, let's kind of start by talking about where we're at right now. Where have you seen the biggest advances in fostering inclusive leadership within healthcare currently? And where do you think we're still falling short?
Sure. So I think that, you know, healthcare has come such a long way. And like I mentioned earlier, when we talk about DEI, we're really still in our infancy stages, right? But I think one of the great things about working in a healthcare organization is that we touch every single member of the community, right, as they're walking through our doors. So I think as healthcare professionals, we have that insight that we're here to take care of everyone. I think where there's opportunities is really as we start to look at and we start to dive deeper into the different types of folks who are coming into our hospitals, right? So whether it's disabled patients who are coming to us. Right now at Baptist, we're undergoing what we're calling the Disability Equality Index, right? Which is sponsored by an organization called DisabilityInn, where we're really trying to understand how inclusive is Baptist Health in accepting folks who come with different abilities. Are we easily accessible on the website? Can people who are seeking care, are the clinicians treating them and understanding what their needs might be? And sometimes we do a great job, and then sometimes we don't do a great job. So, you know, as Joseph was talking about neurodiverse individuals, you know, they may come with a different set of understandings and expectations, and our clinicians need to be ready to be able to deal with those differences. And a lot of time, they may not be ready to deal with those differences because we haven't invested the amount of time or training and conversation to help those individuals become familiar with how do I treat someone. I was just having a conversation the other day with someone whose son is on this autism spectrum, and he was mentioning how, you know, he went out and he was in the exam room and they asked him to take his clothes off, and he did not want to take his clothes off. But the nurse didn't understand that he was like high functioning autism and did not know how to deal with him. So we have to be able to prepare our clinicians really well to deal with the many different types of members in our communities. And I think because we're just starting in that journey for many organizations, it's a process. It's not going to be overnight, but I do think that we're making great strides.
Excellent, thank you, Zoe. Any of our other panelists?
Okay. So this is really brings up a philosophical question, like how do we measure where we're going, and how do we have agreement of what is equity and equality? And I just wanted to share some perspectives, like from a community member, and we still have a lot of work to do. When you shared these questions earlier, I was like, okay, yeah, we have some successes, but we have a long way to go. So just gonna rattle off some numbers just to give us something to look at, right? So like just the gender, so this is medical doctors in Florida. It's about 69% male, 31% female, which is better than a decade ago, where it was about 25% female in the profession. So like we see some trends like moving upwards. But then when we look at the racial breakdown of just medical doctors in Florida, so like, let's see here, 56% white, 15% Hispanic, but only 5.6% Black, where we know the Black population is much larger than that. So when we take a look at the numbers, we still have like a very, very long way to go. And also to like take some of the maybe pressure off of us as healthcare leaders is that like what's happening inside our organizations is also a reflection of the larger things going on inside of our culture. So if this work is difficult and challenging, just turn on the news and we see that there's a lot of heated conversations about this right now. So I feel like we have a long way to go, but this is very worthy work. This is very humbling work. And I think there's just more conversations like this needed so we can really have better consensus and have better tools about strategies that are really working so we can continue to move the needle forward.
Joseph, I think that's a great point. As a healthcare leader, so many times we are at our own organizations thinking, how are we going to move this boulder forward, or how are we going to kind of carry all this on our shoulders? And it really is a lot of time. A great example of saying our healthcare systems are microcosms of really what's going on in the evening news and what's going on in our more global world. So it's an interesting perspective to bring up.
So I think the biggest opportunity that I see is that the people with power are not in positions to make decisions. So it is easy to say, we believe in this diversity, we believe in, I guess the question to organizations should be, do you not believe in equity and inclusion? And instead of allowing people to say, we have diversity, equity, and inclusion, you have to be able to demonstrate it, and your organization has to be reflective of people that have power to make change and make decisions. So if you do not have an organization that has sponsoring leadership, so within the realm of my role within HCA, we have colleague networks. And these colleague networks they're not really affinity groups. They're colleague networks that we utilize, and they communicate. It's a social platform. We have LGBTQ plus group. We have veterans, young professionals, young women, young mothers. I mean, we have dissected it in every way possible. And these colleague networks allow us to make better decisions. So then you're not making siloed decisions. You're somewhere in an office, you're far removed, right? Your career is not there, but you have this group of people that is giving you information about decisions that you should be making that affect the organization as a whole. So I will give you an example of that is when we rolled out our new health insurance program, we didn't realize that we had so many women in our workforce that really wanted in vitro to be a regular part of what, I'll be very honest with you, predominantly our board is male. They are not thinking of in vitro, right? But we have a colleague network of young women that said, hey, I got Viagra going over there. We want to know about in vitro over here, right? That's a joke. We don't have Viagra. I see where your heads are at. But so this allows us to kind of roll out benefits that are to the benefit of the people. So the key to it is also, just like I said, an organization, you should be asking, do you not believe in equity and do you not believe in inclusion? That's a better question for us to keep moving, because for me, we're in 2024, and I don't think it should be that it's not hard. We can make it more complicated, just to muddy the water and make it take longer and make it be more difficult and confuse people about what the issue is. But it really is not a complicated issue, right? Younger women in the workforce want to have children, and some of them have challenges and need in vitro. Make it happen. We can, say, oh, we need this, oh, we need that. Either you are going to cater to your population, and for me, it's my workforce. And for me, I just believe that if your organization is not reflective of the population that you're serving, you are already failing. And then you have to have leaders that make decisions. And I will give a little bit of an example of an assessment that we did for LGBTQ. Because if you are in the LGBTQ plus, I call them my indigo babies, right? If you are an indigo baby and you go for a job interview and you don't get that job, you don't necessarily know why you didn't get that job. If someone discriminated against you, how would you know? Right? You just didn't, right? They had lots of candidates, right? They made a decision and that was the candidate they selected. Well, we put things in place where that can't happen. You know, and you have to be able to put barriers, and you have to be able to have what we call brave conversations. Those types of brave conversations mean, yeah, why didn't, you know, this trans candidate get, you know, who's extremely qualified, and organizations shift. Like I said, they shift the language. Well, we're looking for the right fit. Have you not heard that? Yeah, the fit. Was it you were trying to fit something round in a square hole? What do you mean looking for a fit? The person, you know. So once again, you know, you have to put things in place so that these types of things don't happen, and it really is not difficult. It's called accountability, and it's called being willing to, you know, continue to move things forward. So I have a passion about it. As
you know, I think you make some very, very valid points, because there has to be a starting point.
Right.
And it starts with providing the right platform to attract individuals to your organization that are diverse by offering the right benefits and having hiring practices that welcome that diversity and really build that inclusive leadership. And it really is important that we get it right from the beginning. So, and I'm going to ask Zoe to pop in here for a second, because one of the things that I think I'm very grateful for at Baptist Health of South Florida is we have established, I believe in a pretty short time, some very good business resource groups. And we said we would cover it, and since you covered that perspective so well, Kay, maybe Zoe could talk a little bit about our BRGs and how that has really, to me at least as somebody on the operations side, a really good pathway to develop leaders and to build bridges and have that inclusivity and have truly a resource to call and go to, like Kay is describing. And maybe you could describe where we are with that and how we're doing. And then Joseph, I'm going to put you kind of on the path of helping, after Zoe explained BRGs, the other part of affinity groups and how people come together more in employee resource groups.
Absolutely, thanks, Brian. I just want to piggyback off of what Kay was saying. It's hard to have the conversations, right? Because it takes a lot of courage, and sometimes you're stuck in organizations where they haven't changed for years, and there's strong cultures, but you know, as leaders, we're responsible for having those conversations, as uncomfortable as they might become. And sometimes it's really kind of also understanding when things aren't moving as quickly as you'd like them to. But there's probably a lot of stuff going on behind the scenes and in the background that's preventing the conversation from actually happening. You know, after George Floyd, it was really interesting to see all these organizations who put out statements about diversity, equity, and inclusion. But how many of them actually did something about it, right? Not many. And you know, at Baptist, we did not put out a statement about George Floyd, but we did actually do a lot because of what happened during that time period, right? And our BRGs were born during that time period. And so we call them business resource groups. Some organizations call them employee resource groups or affinity groups. And the reason why we went with business resource groups is because we wanted these groups to be able to be a resource to the business and be able to provide insights and opinions and their thoughts. And so we started out with one business resource group, which was, we mistakenly called them the Gen Y business resource group, right? And so this was when Gen Y was really big, if you remember, like 4 or 5 years ago, and they were trying to, you know, find their way in organizations and move up, and we were not getting any traction with the Gen Y. And it became like Gen Y versus the Gen X versus the baby boomers. I mean, it was just not working out for us. And we got this consultant who came in, she's like, no, you got it all wrong. It's the multi-gen group is what you need to have. We're like, oh, that makes sense.
Should have called me.
Yes. So we called it the multi-gen group, and from there, then we expanded to various other groups. And so now we have a Black BRG, a Hispanic BRG, and abilities, LGBTQ. We have a physician BRG as well, because even though you might think of physicians like, well, they're not marginalized, right? But they have a voice, right? And so at Baptist, we only have about 500, 600 employed physicians, but they play a critical role in delivering care and the organization. And so we wanted our physicians to also have a voice. So we have a physician business resource group. And it has not been like the easiest thing to establish right from the ground up. What we did was we ensured that we had senior executive buy-in for our business resource group. So each business resource group has a senior executive as their executive sponsor. And then each business resource group also has a board, just like you have here, a board with like a chair and a chair-elect and a membership person. And they come together and we ask them to interact with the DEI function in terms of put together some goals and have them focus on 4 key areas: community, career, company, and culture, right? And so how are you impacting through your BRG those 4 particular areas? And getting the BRGs off the ground takes a phenomenal amount of work because you've got to, you're finding your way along about what can I do, how do I interact with my executive sponsor, how do I interact with the DEI function. But in the end, I think they all have these great goals and they assist the organization in figuring out how can we be better for our community.
Thank you. I think you summarized that really well. And again, what I can say as vice president here at this hospital, I have more recently relied on those business resource groups where there have been not only maybe sensitive patient care issues or sensitive topics, but like we're talking about tonight, when you're looking for leaders to get involved and really have a blended approach, because one of the questions was that Adrian was nice enough to post on LinkedIn was, it's about having that mixed decision making, that you don't have, Kate, to your point, maybe one more homogeneous group making decisions for a very large group of people. And in healthcare, when to Pua's definition of kind of where we're going from a quality to matrix standpoint, forget what the right thing to do is, we really got to be there to take care of our communities and do it in an effective way where we can get results. Just if I'm going to give you a chance to chime in there too, because you've worked with me personally on the BRG for the LGBTQ+, and we have worked really hard on the human rights campaign and really making sure that we can score high on that survey. And I'm very proud to say that for, I want to say, going on a good 13, 14 years, BOCA Regional led that number, and now we have 2 other hospitals with Baptists participating. And like Zoe said, some things take time, and we're continuing every day to grow and make sure in all of our communities we're providing that inclusiveness. But maybe you can talk a little bit about how, from an affiliation standpoint, they're effective.
Yeah, so I'd first like to cite some research from McKinsey & Company about, we kind of know that having, whether it's a business resource group, employee resource group, or affinity group, they're good ideas. And we have lots of data that shows they're very beneficial to the organizations. However, there's also how well they're supported by leadership and the hospital structure as a whole. So you can Google this. The McKinsey study did a huge inventory all from big Fortune 500 companies about what is the difference between an effective and non-effective employee resource group. And really some of the findings there is they do need to be really deeply, authentically supported. If they do take time, it's good to invest in that and not try to rush it just to check a box or check a metric, because that's the necessary sort of growing pains that you need to have an effective ERG. So it's difficult, but it's worth it in the end, right? So I just wanted to share that, and I also wanted to share some innovative ideas that I'm seeing other ERGs in large corporations do, and that is sometimes with the ERGs, then they can become little silos, and then they kind of just, okay, we're the women's group and we only, and what a strategy to also connect that with all the ERGs is there's many social topics and medical conditions that overlap multiple different groups of people. And there's a way that once you get your ERGs going, then do synergy events where 2 or 3 ERGs co-sponsor a guest speaker or a topic or a lunch and learn or even CEs or CMEs combined with that. And then that starts to really do this very interesting intersectional conversation within the organization. So it also avoids the pitfall I'm only going to be in this ERG and I only care about this one issue, but to also appreciate how my issues are also interlinked with these other groups here. So I just wanted to like chime in about some strategies that I've seen other organizations doing.
If I could just add to that, Brian.
Absolutely.
I think what Joseph is saying is really important about that intersectionality. And I think the other piece that's really important for us, especially here at Baptist, is that, I was just talking with my leader about this. She's like, we have a lot of different BRGs. She's like, but I'm not sure that everyone can belong to a BRG, right? So yeah, you can belong because you can be an ally, right? And you can have an affinity towards a particular BRG. But I think it's really important for organizations not to lose sight of that, and that you want to have BRGs where everyone can belong to a BRG. So one of the things that we are considering at Baptist is, and we don't have, interestingly, we don't have a women's BRG. We do have, but we talked about that. Should we have like a women's executive group or a women's networking group? When we have one for veterans as well, and Asian Pacific, but we're also a faith-based organization, and we don't have one for interfaith either. So that is something else that we're considering, right? And so, when we launched these BRGs, somebody actually said to me, like, what are you doing about white men? Right? And, it was a good point. Like, what are we doing about white men? Because they're really, unless, yeah, you can be an ally, but is there a place? And so sometimes these conversations can get really dicey. And, some people might say, well, do white men need a BRG, right? Maybe they don't. But we don't want to be exclusive either, right? So it's, you have to walk that fine line where for us at Baptist, it's about inclusivity for everyone at the exclusion of no one. And so that's really what we're trying to drive at, and really figure out, like, how do we bring everyone into this BRG conversation in a way that everyone can feel like they belong? Because the last thing that we want to do is to segment our population because, we've got a veteran person here, and we've got an LGBTQ person, and we've got a Hispanic person. Like, we have enough labels in our life. We don't need that as well, right? But it really is about how do the business resource groups add value to an organization, and how do those executives really support? And we're grateful that our executives are very supportive of our BRGs, because without them, they would just be social groups. And we do not want them to be social groups, right? I mean, we can socialize on our own. So I just think, it gets a little dicey when you do this type of work. And I do think it can get really difficult, especially in the world that we live in today.
So it's interesting that you said that. We had the conversation, and I will just tell you, we do not have a white male group. And the reason that we don't is when we look at the data, they are not a disenfranchised community. Even when we broke the data down within our own organization, predominantly they were the decision makers. They were within the highest echelon of income, and they were the group that stayed employed the longest. So we looked at information through McKesson that talked about, when layoffs happen, just basic layoffs, right? Predominantly who are affected are women, women who predominantly are heads of their households more now than they have ever been. So we did look at that. We do have a lot of white men that are sponsors in our groups, in our colleague networks, because they understand, it's hard to accept that, you've kind of always been at the top. And so you have to get this uncomfortable feeling to be like, I'm not at the top. I worked hard for what I have too. Oh, but no, nobody tried to touch me while I was trying to get a job. So yeah, so maybe, there's something in there for me to kind of take a look at. And more than not, they pull us along more than we're pulling them along. But another thing I wanted to go back to, the incorporation of leadership. Organizations really have to get to a point where there are metrics associated with diversity, equity, and inclusion. Within my organization, we do have a metric. It is built into performance evaluations to make sure that we are touching on all those phases of inclusionism. And we do make sure that everyone is included in decision making. And your evaluation as a leader is if you have been inclusive. And we have to move away from this conceptualization of, oh, well, you know, I support you. I support your growth and your development. And I challenge everyone in the room to move away from when someone says, no, I support you. Anything that you want to do, I support you. Tell them I don't require the support. I need a sponsor. So let's move away from, you know, we support diverse populations. We support blah, 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 blah. Yeah, okay, yeah. What they need is sponsorship. How are you going to help this person get from point A to point B? And it will be on your evaluation to see if that happens, right? And so again, you know, it's nothing wrong with touchy-feely, right? But if we're going to make an impact and we're going to make a difference, right, we have to be able to kind of have that brave conversation and say, you know, I noticed that, you know, you don't have anyone that doesn't look like you that works for you. It's very strange in a population of Latin American population that everyone is from Venezuela. And you're Venezuelan, but we have Cubans, and we have Ecuadorians, and we have El Salvadorians, and we have people from Chile. You know, is there a reason for that? And I know that that's a very difficult conversation. It might be softer for me because I'm in human resources, and part of my role is to have those types of uncomfortable but brave conversations. But you have to have them because sometimes people have unintentional bias, and I know that sounds a little bit crazy, right? But statistically speaking, one of my degrees is also in psychology, but people are comfortable around people that are like them. You know, sometimes it's not somebody just purposely, you know, and when you make that person feel uncomfortable because you're a little bit different, it's, you know, and they make decisions that are more comfortable for them. So sometimes you have to look at that and you have to move away from this idea of support. I support this process. I support diversity and equity. Well, we need you to sponsor. We need to see how many people you helped get through the Leadership Institute and how diverse that group of people were. So, yeah, I think we just have to kind of put parameters around it, but not let it kind of, you know, start living and growing kind of on its own, put some parameters.
I think you have to be really intentional about it, right?
Absolutely.
So like when I joined Baptist Health 13 years ago, first time into healthcare, and we were meeting with the chief nursing officers, right? And I had a nurse manager reporting into me, and she's like, now, they're all gonna be white women, and they're all gonna be blonde. They all look the same. I just want you to know that, right? And I'm like, really? She's like, yeah, it's just the way it is. But you know, 13
just the way it is.
Just the way it is.
And I'm Cuban, right? Thank you.
But 13 years later, right, when I say you have to be intentional about it, and we were starting a Nurse Executive Academy program, right? And so we were identifying who were our high potential nurse directors and AVPs of nursing and so forth. And we were really intentional about who was going into that program. So there were men, there were gay men, there were Black women, there were Hispanic women. I mean, so today, when you look at our chief nursing officer population, everyone's represented, right? So it's not just the blonde women who were there, no offense to the blonde women in the room, but you know, it was just, I mean, when you think about how much progress, and when you think about how much progress we've made, right, just because there is an intentionality behind it, it really is remarkable. And so that's what gives me hope that things can be different. But I'm going to go back to saying, like, we can't leave people behind, right? So just because you're a blonde woman doesn't mean that you can't be considered for
big group,
right, for a CNO position. We have blonde women.
I hope I
right?
could be considered. Absolutely. I have to look at my staff and start to diversify. And I would like to be in a CNO position someday, and I don't want to be not considered just because I color my hair blonde.
But that's
you color it?
No, it's all gray.
Oh, okay.
All right, so I'm going to say, what's wrong with gray?
This is why inclusive leadership can be fun. Have these conversations and bring some humor to it too.
So I hope when I'm sitting in front of you, consider me.
Absolutely. We consider everyone, right? And that's really the point, is that we need to like be open to differences.
Absolutely.
And be able to consider everyone regardless of who they are, but really look at the backgrounds that they bring, the experiences that they bring, the expertise. I was telling somebody, I was so offended 4 or 5 years ago when a recruiter reached out to me and said, oh, we'd like you to join us in South Carolina for VP of HR position because you're a Hispanic female. I'm like, no, thank you. Like, no, thank you. I'm not interested in being your VP of HR because I'm a Hispanic female. They just wanted, to check the box. And to me, that was just so offensive because I'm so much more than a Hispanic female.
Very good points all around. Joseph, I'm going to ask you to help us bring this together and help us understand when we're talking about all these different equity issues. And I'm going to ask specifically to bring the conversation more towards health equity for the communities we serve. How do you intersect this inclusive leadership conversation we're having with that health equity piece? Because again, you and I have worked a lot of it on one specific segment of the population, but Zoe's mentioning how we're really focusing on it too with the abilities community. And how do we make sure, again, that leaders and this inclusivity that we're talking about, because at the end of the day, we all want to feel welcome and we all want to feel engaged. And while, again, and this is even a controversial statement at times, I love that we have all these pieces in place to support all these different aspects. But I know it's a little utopian, but I hope I am still alive the day that maybe some of this isn't a conversation, that we're really at that point of really just being an inclusive group of human beings, period. Wouldn't that be amazing that we wouldn't need all this conversation? But I do want to bring us back here tonight to make sure we talk about where this intersection of inclusive leadership and health equity really happens.
So, in other industries, it's just about like the employee population and of course legal compliance. But in healthcare, we have a whole other set of data that we can look at is healthcare disparities. So again, just to refresh us with some of the disparities. So just being a Black baby in America, you're twice as likely to not make it past infancy. We still have instances of discrimination of, and particularly Black women who ask for pain medication in the hospital. Yes. They do not have the same dosages given out when we take a look at the data. So as a hospital, that definitely can center our strategy and relate to governance and give us like a guiding star to look at. When we take a look at some research from Deloitte about DEI, they suggest also using your community health needs assessment to also be integrated into the DEI conversations and processes.
Can I pause you there? How many people by raise of hands do know that organizations do community health risk assessments and utilize them? Okay, because we should all be doing them as part of kind of our standard approach, but what we do with them is what Joseph is, I think, alluding to and the impact of it. So thank you for letting me kind of jump in there.
Yeah. So, and again, I think the purpose of this panel is to really just share ideas and practices. So like if you haven't done or you don't know what your healthcare organization's local healthcare needs assessment are, that is a really great place to start. And because I'm in a nonprofit, there's also grant funding that you can get because if you find that there's high number of disparity population in there, so just another strategy that you can use to incorporate. And that's when we're invited to talk on ERGs or do CEs and CMEs, that's what we focus on. We talk about the different subpopulations and the disparities in outcomes, and then practical best practices that we can implement from a clinical and also patient care perspective to start moving that needle so the numbers get more in alignment. I can't recommend that enough. And I don't remember all of the orders of the questions, but I just wanted to also mention, like your board needs to see that document and have a conversation around DEI using that data. And just to also throw out there another recommendation, because I've seen other organizations do this, is at the board level, the board themselves create a DEI committee within the board that also is really owning this, and then that has like sort of a lockstep accountability all the way from the top down. So just wanted to mention those strategies.
Yes, sir. Can I react to that? So I'm Rudy Molinay. Besides being a professor at FAU, I'm the first openly gay board chair of Holy Cross Health. So Catholic hospital, openly gay. Never would have thunk. But I want to echo what you said, Joe, because I think what I've noticed on our board since I came on the board as an openly gay, proud gay man, in a Catholic hospital, faith-based hospital, the response has been amazing and has really increased all the diversity on the board, because now we're looking at it from all the spheres, you know, and that includes white people too, right? Not cisgender white males, right? But I'm curious your thoughts, this panel, on what kind of work are you doing within your organizations to develop the board? Because I think you talk about, Kay talked about it earlier too, governance, right? The governing body, it's a fellow exam question, by the way. When you go for your fellow exam, the ultimate deciding factor, no matter what the question is, it's the governing body, the board. That's who's the responsible party. So I'm curious if you guys experience, if any, on that realm, and any advice, because we're looking to do more.
Yeah, I mean, at Baptist Health, we, like Holy Cross faith-based organization, we have a lot of pastors and reverends on our board, right? And over the last few years, we have taken significant efforts to diversify the board, right? So we have more women. We do have openly gay females on the board as well, Hispanics, young, I mean, a lot of the people on our board were older men. So now we're bringing in younger people from all different areas of industry as well, and not just faith-based individuals. So I do think that it takes, because of the progress that's been made, and I think the increase in awareness that DEI has brought into our communities, it has forced the board to also look at, you know, how do we diversify? And I'm really proud of the board that we have at Baptist Health, because, you know, we have an HR committee of the board, and they push us, right? They ask us to look at, you know, how many people with disabilities are you hiring? And do you have a program in place? And so the board really does provide that oversight and that insight, and it's because, you know, there's a lot of diversity on our boards, and I'm looking forward to it continuing to be diversified.
Representations, we have a new board member who's a quadriplegic, and there's been no one on our board with that lived experience, so we have to make sure when we have our board meeting that there's a bathroom nearby and there's a place for his attendant to be able to be with him if he needs to be. So if we look at diversity, because it makes us better, right? And in this state especially, kind of the elephant in the room, right? In this state where diversity is becoming a 4-letter word, even though it's only 3 letters, DEI. You know, I think
DEIB and belonging.
Yes,
made it
so it is a 4-letter word. There you go. But I think it's important in healthcare that we be that beacon, because at the end of the day, there is a basic need to be healthy. No matter who you are, who you love, who you pray to, who you don't pray to, what your color is, what your gender is, your identity. And I think in healthcare, we have almost an incumbent responsibility to be that beacon when maybe the rest of society is freaking out over here, lots of noise. But, you know, what do we do when that person comes to our ED who's, you know, having labor problems or is having chest pain, and, you know, they're not sure they're going to be treated right because of who they are. And I think that is the essence of really healthcare, right? And that's what I try to teach my students. It's always look beyond the bureaucracy and the checking of the boxes that you all mentioned, but what do we really do so that we can give health to people? Because that's ultimately what we're supposed to do.
Right. I think that the biggest piece of that as well is that we have to just like drop the facade, right? The data that you gave, those are facts. They're not attack, it's fact. It is a fact that if a child is a minority born in this country, that they have a less likely than mortality is a fact, right? So it's a fact. So we're not going to argue about facts. Those are facts, right? There is disparity in LGBTQ plus votes. It's a fact. It's not a personal, you know. And if our goal is the commitment to the care and improvement of human life, which is healthcare, right? Which is our mission, right? Then we have to deal with those facts. And to the point, we have not dealt with those facts, which is why outside organizations are now putting things in place that we didn't put in for ourselves. That's why now Joint Commission has an entire, right? So because we do it, no, you're not. And that's why the Office of Minority Health have come in with LEP guidelines, limited English proficiency guidelines, and all those things through the Office of Minority Health. The reason that those things are being pushed now is because you didn't push up, right? And so now they have to make you. And we are a part of the Health Equity Index as well, but I feel even ashamed for that an outside organization had to come in and extrapolate data to make us look at facts in order that we change. It is not supposed to be that hard. So yes, health equity index, very, very important. Now Joint Commission is moving in and basically saying, I'm going to conduct this tracer, but I'm also going to look at who this patient is as I do this tracer. Whereas I don't know if many of you are healthcare. Before it was a chart review and that was it. It was sort of a blanket, process of how the person was treated and what care they were given. Now it's like, well, no, let's see. And when we talk about diversity, we have to talk about all parts of diversity and bias. So I don't think that people separate bias, prejudice, and discrimination versus racism. Those are all completely different things and different genres. And I'll give you an example. In my past life, we had our OB unit, and we always had, what we thought was a great OB unit until someone came along and put some metrics to it. And what we found is that we had a younger population of African American and Hispanic mothers that whenever they took their surveys, they were very dissatisfied, even though we were in the 85th percentile overall. When we extrapolated and looked at that data and stratified that data, we said, why do we have this population? If we're in the 88th percentile, how is it that we have this population? Well, what we also had in South Carolina were good old older Southern nurses who were the caregivers who didn't like the idea that this young Hispanic mother was unmarried. And that, did she not provide care? Yes, she did. She provided care, but did she provide the equitable care? No. right.
Well, I would ask, was she aware? Because
Right.
so many times people aren't even aware of the biases
That's what
they're bringing.
That's what I was saying, unintentional biases. So we looked at that information and we said, oh my goodness, we need to educate our workforce. We need to step back a little bit because, yeah, we're at the 88th, but boy, we could be at the 89th. I mean, we could be at the 90th. We could be at, 99th. We could be a leader in the industry. Why do we have this little barrier? And what we identified is, they did have some intrinsic bias to this young person who decided, and we even had some, go back to the in vitro issue of mothers that wanted to be mothers but weren't married. They had a big problem with that. They didn't realize that they had a big problem with it because they were married since they were 24 to their childhood sweetheart in the same little town that they all grew up together and right? Yeah. And they all, were one religion and they all were kind of the same, right? But they didn't realize that we had this, so again, that brave conversation and that brave look back to go, hey, just want to put it out there, we have this population of unhappy people. Well, that really doesn't matter because we're almost in the 90th percentile. Yeah, but we're not. and we want to get there. So how do we get there? Oh, we need to look at this information.
And did it change?
It changed.
So I'm going to ask a question. I'm going to take us back a little bit. And Rudy, I think you're going to like this one. And Holy Cross is lucky to have you down there in Fort Lauderdale. Joseph, because I think you do a lot in the training arena, I'm going to kind of ask you, and I'm going to welcome anybody who's in training and education and kind of chime in as well, even from the group in the audience. But we obviously have a real opportunity here, right? And that's going to involve training our next generation of healthcare executives. And we have a lot of young executives and clinical leaders in the room today. How do leaders foster diversity, equity, and inclusion? What role do you see education and professional development playing in that? What policies, practices, procedures do you see helping us guide our organization? Because healthcare is pretty structured, right? Whether we like it or not. So how do we help train our future executives? How, even as us having this conversation tonight as the American College of Healthcare Executives, to bring this very robust conversation, and the panel's been doing a great job with that. But how do we help evolve this?
My most familiar experience is with the clinical training. So Yes Institute gets invited to do like guest lectures and clinical conversations with like Miller School of Medicine at UM and FIU School of Nursing and Nova School of Nursing. And so I've seen it from the clinical side, but I kind of wanted to learn and ask from you all, is that happening like somebody that's on like a healthcare administration track, how much DEI is in the curriculum? So that's a conversation I would love to have with faculty because we see it working really well. Okay, I see a negatory response, okay.
Well, I can tell you now, we can't in Florida, in a public university, we cannot talk about it.
I'm happy to have this conversation after the panel of strategic ways that we're engaging with, and I'll just include it here. So for example, we partnered with the National Park Service, so they had a psychological safety stand down for all national parks back in February. Our local national parks here, so Everglades, Big Cypress, under the umbrella of psychological safety, and you can't do DEI unless there's some parameters for psychological safety.
Indeed.
That right now is a state law compliant and very baseline, employee safety and wellness and preventing risk management and lawsuits, or at worst, just some bad post on TikTok about something that went down at your hospital. That is all in the realm of stuff that is, again, compliant. So we did this phenomenal session with national parks. We only did an hour. One was on Zoom and one was on Microsoft Teams. Just in that, with 160 people in the boxes, they said people started opening up and unloading and venting about all this unpsychological safety that has been in their workforce. And we want to bring you back and actually do an in-person session. We want to do one for just supervisors by themselves, because depending on the generation age that you're in, years ago, they didn't even include this as a subject matter. But now in the up and coming generation, that's the opportunity we have, is the younger folks coming up. If they get this in education and they learn about it, and there's a science to this, there is data to this, if they get that, then they're not stepping in the hospital like at square one. A lot of the consultation we're doing for organizations is because they didn't get this in school, they didn't get to talk about this, they didn't get the learning and the knowledge. So now a lot of leadership is playing catch up. And so we have to catch them up while we're also just huge opportunity to do it. And I have working strategies to do it that's compliant with Florida state law.
I'd love to talk to you because
Yes.
it's very challenging.
I think the other piece of it too is that, we have to just be honest about the fact that even our physicians, they go through medical school, no one talks, they learn about the body, but they don't learn. I think one of the key things that you mentioned, even about Black women and the idea that, your pain is not, you can take it. That's an essence from slavery, that your pain is you're not in pain. And we have to understand and bridge the gap between why are those things in place? Well, they're remnants. It's not as blatant as it was back then, right? Because we're growing, right? We're growing, our humanity, our essence is growing, but those things are from there. I work in healthcare, you guys, and there was a time when healthcare was completely segregated. They had completely segregated units. And if we did not have Medicare and Medicaid that were going to receive monies from the federal government to care for patients, we might not have made the progress that we made, right? There was a time in healthcare where women could not get healthcare unless their husbands told them that they could. So we have to understand where these things evolve from. It's not just the right now, you guys. It's like looking at a tree that's tall and not being able to look at the roots because the roots are a little bit bumpy and they're a little bit rough on your hand. You can't do that. You have to look at where the essence of this comes from. I think of patients not receiving equitable care. That is fact-based data. We have a responsibility in healthcare to do no harm. We have a responsibility to educate our healthcare professionals, right? And so, I'm sorry, you were.
No. I have a question. I just have a question. So, and this is no offense to all the amazing men in the room, but with March being Women's History Month, and there's still I love that you're all about facts and data, because I am as well. And in America, women are still making 82 cents on the dollar, and all healthcare across every healthcare, any field. These are facts, and the most recent survey was just done in 2022. So what are we doing to close that as leaders, as a Latin leader, as a woman, what are we doing for the generations? I know we all have women in our family. Women are still making decisions on healthcare today. Times have changed, the evolution has changed where women are the decision maker for their family's healthcare. So what are we doing to close that delta and the disparities of gender and pay?
I know you're in recruitment, so if you want to take it,
So he's
but
like,
I'll take it.
that's a great question.
I got it. I got it. Okay, so
Well, have you start, Kate, we'll go over to Zoe and
So I can tell you within my organization, so I can't speak for a global, right? I'm not that person, but I can tell you within my organization, we have a process of review. And we have a very standardized way that experience, that education is actually aligned and measured. And the reason that we're doing that is not to put people in a box, but to ensure that no one is able to make an individual decision because we don't know their lens, right? And not that their lens may be good or bad, right? But that we have uniformity and alignment in the things that we do, so that when things are, the light are put on things, things are right? And so I think in the past, leaders individually within organizations got to decide, I'm going to hire Rahat, and I'm going to pay Rahat whatever. This is Rahat, you guys. He's amazing. That's ortho. He's amazing. Finance, controller from my facility, right? So I think once you remove that closed door session where individual people that are doing the hiring get to make the decisions, actually within our organization, the leaders don't have anything to do with pay. They're not allowed to. And the reason that we put that in place is so that there would be some uniformity and remove the biases that, and again, unintentional biases, you guys. Sometimes these are not blatant, people are not running around trying to do harm to people. But again, we have to look at where the root, comes from, right? And so within the workforce, there was a time when women were seen as help. Right? And so it's just like our tipping system, right? So we believe that we tip people as a normal, tipping was from days of old. That was post-slavery. People didn't want to pay people to do work, laundry, and serve because they were doing that for free before, right? And so that's where, I don't know if you guys know, but that's where tipping comes from. Look that up. And so you have to go back and say, why are women paid disparately? Well, they're paid disparately because we were seen as help. That's something that you're supposed to be doing, and you are not equal in footing, right? You're not necessarily the head of your household, right? But after World War I, that had to shift and change because women were staying behind. We lost a lot of people that we loved, right? And women became heads of households. And so that earning changes. Again, I'm a roots person, right? I like to look at the basis of why decisions get made. But that is why the inequity in healthcare. And it talked about that it would literally take another 150 years before there would be equity in pay if there were not some parameters. So I'll speak for my organization. Again, we do not allow individual decisions to be made when it comes to compensation. That is managed within the human resource function. And actually that leader that's hiring has absolutely nothing to do with the benefits package that's offered or the salary.
So I'm going to ask you to jump in here and give another example of an organization and what you think we're doing to move pay equity forward in leadership.
I mean, we're doing the same thing at Baptist, right? Leaders aren't setting salaries, but I think the reason why women are paid 82 cents on the dollar, that statistic has been around since I was 20 years old, and that was 30 years ago, right? And it hasn't changed, I don't think. It really boils down to education and the opportunities that women have from an educational standpoint, right? So when you look at the types of jobs that women are going into, right, whether it's administrative assistants or whether it's human resources or whether it's marketing jobs, I mean, if you take a look at, there are professions that are female dominated and then there are professions that are male dominated. And typically those female dominated types of professions, the women are being paid less for those jobs. Even when you look at human resources, right, which is kind of incredible that you have 80% of the women at Baptist Health are in human resource, or 80% of the human resources team is women, but yet when you start to look at our senior leadership team, you've got like 50% of the men and 50% women, right? So there's still this like inherent, bias around women, But I think a lot of it also has to do with the fact that what you were alluding to is that women are caregivers, and we have to take care of our kids, and we have to make sure the kids have their homework done and that dinner's on the table. And there's just so many other pressures that women have that they may not be able to have that executive high-powered job that's going to pay a little bit more. I have a friend where the woman that goes out makes all the money and the guy stays at home and he's the Mr. Mom. But we've got to put support systems in place to be able to help women be able to do everything that's expected of them to be able to do.
So I just want to jump in here.
And by the way, sorry,
before you go there.
If you look at the demographics in college, and the professor can probably tell us, but we're leaning towards having more women in college now than we have
80% of my MHA students are women.
Right.
I'm proud of that.
Absolutely. So I do think that the pendulum is going to swing, but it's going to take a little bit of time. Sorry for interrupting.
No problem. So one thing that I was going to say is something that we did come up with within our Women's Colleague Network was this idea that women are less likely to negotiate their salaries. So men are very comfortable negotiating their salaries. They are already in a position of power. As I mentioned earlier, why we don't have certain affinity groups is because they already have the power. We don't have to give them it. They already have it, right? And so women are less likely to negotiate for their salaries. And more. So when I say and more, there's those little perks, right, that are built right into the unspoken perks. Women are less likely to, step up because they're so happy just to get in through that glass ceiling that once they're in, they're like, all right, I'm up in here, right? And so I think that also goes to, through the Women's Colleague Network, this need for empowerment of women, and also for folks that are hiring to not bias themselves to say, oh, look at her pushing for her salary. She's such a...
You fill in the blank.
I don't know that we should hire her. She's very difficult. She's very outspoken. Right. Do you know that she called and asked, was there an additional stipend for that? The other piece of that in the study that talked about that women are less likely to ask for compensation due to the expansion of their roles. And the study showed that men don't ask, but they're given it. Wow. Right? So women don't even know, they don't even, it's like, will you do this extra, Kay? I'm like, yeah, sure. I know how to do that. I need to put these in together right here. This is what we're doing. Okay. Well, whereas I wouldn't ask. Of course I'll do it, right? But there's sort of this unspoken thing where women don't even know to ask. That's the first part. Don't feel empowered to ask, because if you've not been in the club, you don't know the club rules. You don't know the club rules, right? And so I didn't know, this was an extra $2? I didn't know that this was $2. So I never asked. And so it got done, right? But the study also showed that men don't ask either. So what does that mean? That there's an intrinsic bias in the process associated with compensation. So again, there's some things there.
Do the BDR groups that you have address these issues?
Our colleague networks, yeah. That's how we find them. That's how we find them. Actually, we have this WebEx process, and we ask questions and get feedback in real time so that we are making decisions with them. They are making decisions with us in real time. Yeah.
So we're kind of rolling into it. I'm going to keep going. I love this group's engaged. Go ahead with your question.
Okay, so Roxy, my question was from a topic 3 topics ago, where we were talking about healthcare. Well, for our leaders, how do we combat getting people to come into the organization that looks like the community? So what are you guys as leaders, or us as leaders, what are we doing right now to campaign to different people of different background and affinity groups to say, okay, I want you to come to BOCA RATON's, and excuse my accent, regional
I love your accent. I love it.
to work for me, like what are you campaigning? Like what are your slogans? Like what are you doing monthly? Like are you having come here because each month we identify a specific group of people and we want to acknowledge for March women for whichever month we're highlighting this group of people to make it attractive for more leaders. Like what are we doing in that aspect?
I think really you've got to cast a wide net and you have to feel comfortable going outside of like where you always go to for people. And so what does that look like, right? So whether you're looking at hiring veterans or you're working with different veteran groups to bring in more veterans into your organization. We've got a big program to hire folks with disabilities. So we partner with various community partners who have candidates who have disabilities. And so then we're able to target that population. So I think you have to really kind of take a look at who do you want to bring into your organization? How do you cast that wide net? How do you partner with different individuals in your community who can help you achieve it? Because you can't do it on your own. And you just have to be open to the many different opportunities that are out there. Because otherwise you are going to continue hiring, the same thing that you've hired in the past. Something that you said earlier, many years ago, I worked in an organization where the chief operating officer, it wasn't in healthcare, but the chief operating officer said, I'm going to give Scott more money because he's got a family to support, right? And he said this to a woman. The
root of that tree is rotten.
I mean, he actually said that like to another director in the organization. And it was just kind of like, so Shirley doesn't have a family to support, but Scott does, right? And so it's that kind of mentality that needs to be rooted out of organizations. And what was even more shocking is he actually said it out loud. And he thought that it was okay to say it out loud. Now this was in the mid-90s, right? I don't want to date myself, but you know that those conversations still happen behind closed doors. And that's why I bring it up, because those conversations happen. And I know I digress, but I think it's because I think we're all very, very passionate about this topic, and there's a lot of great things that we've done, but I think there's also a lot of opportunities. Go ahead.
I'm going to go ahead and I'm going to take one more question, and I feel bad. We're reaching our time. It has been a really good, robust conversation tonight. So let's take one more question from the room, and we're going to give the panel the last word. Chris, you've been having your hand up.
Yes. One of the things that I'm a South Florida local, born and raised, and to me, diversity comes with the territory. I've always joked around and said I'm too fat to be racist because I don't want to cut myself off from all the food.
I agree.
It's so true.
I like the food.
So my question is, how do we change the diversity in other places? In my eyes, I see it as a struggle to build a farm network almost. South Florida, we're diverse down here. We're way more diverse than everything between A and B.
Right.
So if we don't change everything between A and B, that's the farm system. You're getting these people who are growing up in Missouri becoming COOs that can come down to South Florida and become a CEO.
Right.
They're getting the experience because they're the most qualified candidates. Not because they're a white male or a white woman, but because they got the experience running a hospital. How do we change that in the places in between where the struggle is, well, why are you trying to bring DE&I into my college? Now you're brainwashing my kids.
So I'll start addressing this very briefly because I know time is coming. So other work that I've gotten to do is in North Georgia, so like right in the middle of the Bible Belt, Alabama, very like rural communities on gay and transgender topics. And you would think that, oh my gosh, you're going to the rural South to talk about gay and trans, right? And I'll share this one story. It's about it's about supporting people connecting the dots. So we were working with North Georgia College and State University, and they're also one of the military schools. And they had called us in because there was 3 suicides by guns. And they said, Joseph, this is the South. Everybody grows up with a gun and everybody knows how to use it. And these were not a gun accidents. We strongly feel that, this was something else. And so I'm a big proponent of it's how we shape the context. Nobody wants someone committing self-harm or dealing with the aftermath and devastation of a loss like that. And that's where we started the conversation. We partnered with the religious leaders of the community, and we sat together in these like very brave spaces. But then I've got the minister right here, so any religious concerns, we can address that. But we're all here because there has been some, we suspect there's been some self-harm. And it could have been about, you know, sexuality, because we are here in our community. And from that, and we've supported NGCSU over the years, that in North Georgia, they now have a GSA on their campus and many other things along the way. But we have to start at health and safety and well-being, and that's something that I think all Americans really agree upon and want to come together about.
So I think for me, I see a nurse at a bedside, and she has to have knowledge, competence about that patient, right? So you have to know, you know, the age. If it's an elderly patient, they have very thin skin. You have to know, you know, when the medication is given. You have to know everything. You have to have a cultural competence. And to your question, I think that leaders should have to have a cultural competence. Is it the norm? No, not necessarily. But if you're asking me if you've got a magic box over there, I'll tell you, I think that if an employee that has an influence on their interaction with one patient has to be culturally competent, then a leader that has the power of influence over an entire organization certainly needs to have cultural competence.
I think that is a great, great point. And the point I kind of want to say, let's end on, Zoe, out of respect for you, I want to give you a final voice too. I know just Kay had a moment, I want to give you. Anything else you want to add?
I think we've made a lot of progress, and I think we need to celebrate the progress that we've made, right? And certainly there's a lot more progress that needs to be made, and you know, we all play a part in it. And so we each need to look within ourselves and figure out, how am I contributing to making healthcare more inclusive?
I love it. I want to ask your guys' permission. I really want to manage time. I have seen this gentleman put his hand up 2 or 3 times, and I do not want to leave you out. If I have your permission, I'm going to give you the last quick question for me, but we're going to do it quickly.
I feel like there's an underlying proclivity when we think about DEI, because some of us are kind of like sectioned off into different groups, and we kind of go in our mind about certain thoughts about DEI. I wanted to know from the panel, like, what are some of the underrepresented issues when we talk about DEI? Like, I think, I forget your name, all the way on the right. We had talked about
Zoe. She's got
Zoe.
Zoe. You had talked about seeing a, there was a, I'm trying to remember, there was a patient who was going into an exam room. Like, sometimes we don't think about like some of the issues, like autism. Like, patients had autism. So I just wanted to hear from like the panel, like, what are some of like the underrepresented issues when we talk about DEI?
What do you think the hot DEI underrepresented pieces still are? I'm just going to do this real quick. Zoe, or anyone who wants to take their first thought.
I think veterans, right?
Veterans.
Yeah, I think, you know, a lot of times we forget about our veterans and what they've contributed to our society, and you know, they come back from wherever they've been, and then it's really hard for them to get a job because they may come back with PTSD and all sorts of different psychological traumas. And so sometimes we forget about, you know, how do we help bring in veterans into our organizations, and how do we care for our veterans, even though, you know, you've got the VA and all of that, but I think veterans are often overlooked.
So we still have an ongoing mental health crisis that intersects all kinds of different groups of people and backgrounds. There is still large mental health stigma. I know that the topic of transgender gets like a lot of airtime right now in the media, but gender non-binary folks and also intersex folks that are part of the Pride community, they also are kind of just not talked about and included, and have some of the more like really, you need good clinical and patient care competency. So I would also say neurodiverse, and I'm probably leaving people out, I don't want to do that, but that's just off the top of my head, some of the groups of folks that are not really included right now.
Thank you. Okay.
I've talked too much. No,
What group do you
I think
think?
I think it's definitely our mentally ill population. And I think somehow we have to move away from this ideology that mental illness means crazy, mental illness means insane. That's just not true. People are have mental illness, come in and out of mental illness multiple times within the span of their life, and we need to be able to have safe and psychologically safe spaces for them in order to just exist and have their human experience without being judged for it. So definitely populations at risk.
Well, I want to thank all of you, and I don't think you can ever say enough, any one of you. I have to also actually turn this way, because when I agreed to be a moderator tonight, and I normally have no problem getting up in front of a group of people and speaking when somebody asks me, and I was humbled to be able to do this, and we did a great event last year too. But I really do want to thank Harula for allowing me this opportunity to do this and facilitate this program. But Charles, I really want to recognize you, and sometimes people don't realize this, but I'm really proud of ACHE, to be honest, the American College of Healthcare Executives overall. But I'm really proud of this chapter. I've been part of it for about 6-7 years. I've been on the board 2 years, so I'm just going to say I'm still a newbie, because I've really gotten more involved as a board member. I've been part of a lot of associations. This could be a challenging conversation to have, especially like you said, with our political environment. We have a president of our chapter who's comfortable with it. We have Charles, this is Charles Felix. He's actually heading our programming, and I'm excited. Where's Juan? I don't want him to.
He left already.
Oh, he left. Jenna is our past president. We have some women and men. Charles is, again, our programming gentleman.
Old men.
That don't step away from providing you programs that are meaningful. We don't want you to come out on a Thursday night and take time with us. It's fun to network, absolutely. But we really, as a board, make a conscious decision to provide you with great content. But I have to give credit where credit is due, and I'm going to have a hard time next year following Jenna, following Harula, and Charles. I keep saying, stay close, because I'm really very grateful, and I hope you feel the same way. I'm going to ask you to do 2 last things. Our panel, I'm sure, will stay around a few minutes. If you have additional questions, we're certainly not kicking you out. Please do scan this QR code. We want your feedback because it helps us provide better programming. And lastly, please, I'm not going to switch aside because I really do want you to do this survey for me for 2 minutes so we can continue to grow as an organization. Please click on LinkedIn if you haven't. Follow us there. There's a lot of meaningful content that we post there. A lot of discussion, and we keep going. It doesn't have to be once a month. Thank you so much for coming out tonight. And thank you for a big round of applause for our panel, please. Thank you, Joseph, Zoe, and
Zoe, I'm a fellow Hawaiian too. I live in Make sure you don't fall asleep.